very much for inviting me to the HERA International Symposium to speak about real-time healthcare data in OECD countries. The OECD has been working over the past 10 years to support countries in strengthening their health data infrastructure and the governance of health data. We developed a legal instrument called the Council Recommendation on Health Data Governance that asks all countries to develop a national health data governance framework that would allow for data to be developed, to be accessed, to be shared and used while protecting individuals' privacy and health data security. And we're now in the process of monitoring how those frameworks are being developed and implemented in practice. And that's some of the data that I'm going to show you today. And we're also working with individual countries one-on-one to strengthen health information systems. And I'm very pleased that we're working right now with Korea on such a country review. And we hope to be able to bring forward some helpful policy recommendations to take what is a very strong health information system and really make it even more powerful for the 21st century. So why would we want to develop real-world evidence about medications? Why do we want real-world data about real patients and their healthcare experiences and their outcomes? Well, we want that real-world evidence to support health technology assessment and the post-market surveillance and really safety monitoring of drugs in the real world, to be more efficient about selecting clinical trial cohorts and add real-world data to follow up their progress, to have information to guide our decisions about reimbursing drugs and pricing drugs, to develop really good clinical care guidelines for clinicians and to evaluate whether those guidelines are actually being followed. And as the Korean system with the JUR program is showing, you can give real-time guidance when clinicians are prescribing medications and pharmacists are dispensing medications to take the right decisions to preserve patient safety. And you could even take that a level further, and you could develop the data to provide real-time decision support tools for clinicians about treatment pathways and prescribing that's tailored to the patient's needs. So if we wanted to have really good real-world drug safety information, it would have four main components to it. It would have information at the level of patients about the medications that they are consuming, including the dosage of those medications. It would have patient-level information about healthcare utilization. It would have patient-level information about the outcomes for patients from following those treatments. Are they getting better? Do they have worse outcomes? Have they died? Mortality data. And it would also give us important characteristics of patients, sociodemographic characteristics, factors in their environment that might affect their outcomes. And it should have patient-level information about diagnostic and clinical tests and diagnosis and the results so that we understand the progress of patients and the treatment that they have been given. So if we want to have all that kind of information, it makes a difference where the data on prescription medicines comes from to develop national health data. So as you can see in this chart, in most countries, data are extracted automatically from electronic claim or billing records. And it is claims data that supports the Korean prescription medicines information. But we also have a large group of countries that are developing their national prescription medications data from electronic clinical health records. So they have a national EHR system, and they're able to extract data from that system. So they're getting the more detailed clinical information into their prescription medicines database or registry. And then we have in Finland, where as part of the EHR system, they have an e-prescriptions depository. They extract the data directly from there. We still have countries that are working with paper records. And in the case of the United States, of a highly fragmented health system, their national data depends still on a survey. It also makes a difference if you're able to link your patient level data about prescription medications to other data so that you can follow the pathway of care and you can observe the outcomes for patients. So we have a fairly large group of countries that are able to routinely link their national prescription medications information that's available at a patient level to their patient level hospital and patient data. We also have fairly good sized groups that are able to link to mortality data, emergency care data, mental hospital and patient data, and formal long-term care data. So this is a busy chart, but what it's showing is that while many countries are linking healthcare data and mortality data, fewer countries are actually linking to contextual data that could provide more information to understand outcomes for vulnerable populations. So the best sources of data for understanding these background characteristics of the population are this census information and a population registry if your country doesn't have a census. And well, we have some countries that are building these capabilities. They're certainly not as strong as they could be. And there was, an excellent example in the United Kingdom from the Office of National Statistics, where because they've been able to routinely link healthcare data and census of population data, they've been able to do this quite quickly to respond to the COVID-19 pandemic and really identify, from having done that, vulnerable populations in terms of risk of developing the disease, or access to care to treat the disease, or access to vaccination. So this is an area to expand further among OECD countries. Just to highlight particular progress in the Nordic region, where there's robust and has been for many years capacity to link across different types of databases to create these more developed sources of information for drug safety. You can see the Nordic prescription databases are linked to health registries, but also other sources of data like surveys, biobanks, clinical records, and to that important background information coming from population registries. Korea really stands out for being among a very small group of OECD countries with national health data in real time. So you can see at the top of this chart for prescription medicines data, there are only 7 countries where the records in the data set are no more than a week between when they were first collected and when they're available for analysis. There's also 8 countries that have real-time primary care data, and then for other types of data, there's very few countries that have developed that capability. Now, this data was measured just before the pandemic hit, and as a result of experiencing the pandemic, countries are now reporting to the OECD that they've made some significant improvements in the timeliness of data, particularly data directly related to COVID patients in terms of hospitalizations, but also particularly mortality. So in this chart, there's only 2 countries with real-time mortality data. but this is now expanded to 8 countries. So, in a very, very short period of time, difficulties with national health data have been really addressed in an accelerated way, and really sets a new tone for where we will build from and what we can do going forward. So countries have been working on the power that they can gain from extracting clinical data from national electronic health record systems. And this capability is an area for much greater development in Korea. But just to share progress in other countries, you can see there's 16 countries that are using this clinical data now routinely for public health monitoring, 12 countries for monitoring patient safety, 10 for monitoring health system performance and extracting data for medical and healthcare research. And there's also small groups of countries that are applying data mining, predictive analytic techniques, and that are linking data in the EHRs with genomic, environmental, and other contextual data. We have a large number of countries that are reporting the progress they're making in improving clinical data as an information resource. So 23 countries have joined one or more collaborative efforts, which are multi-country efforts to develop standards for health data terminology and exchange. And countries are also working within their own jurisdictions on policies and projects to improve health data interoperability. And a particularly interesting new development is we've got 17 countries that are adopting HL7 FHIR standards. So we're starting to see some convergence in the global community around health data standards. And many countries indicate that going through the pandemic has accelerated the development of their electronic health record systems. Just to shine a spotlight for a moment on the United States effort of their Federal Drug Administration and their Sentinel system. So it's a privacy-preserving distributed network based on a common data model with data from medical records and external registries. And it helps to provide real-world evidence for all of those good ends that we were discussing earlier. And I wanted to mention it. It's not providing the full national picture in the United States for drug safety. And you'll recall earlier, their main source of data is still from the Medicare beneficiary survey. But for a growing number of healthcare organizations and many millions of patient records, this Sentinel system is developing. And it has some similarities to developments in Korea. So this slide was presented at a workshop given by the OECD looking at best practices in health data governance. And I think it shows very nicely the development in Korea through a global collaborative research project called OHDISI, the availability in a secure manner of linked data from HERA and from the Korean Disease Control Agency and from other organizations to create a database that was refreshed in near real time, very current data on COVID-19 patients, and then the data was available to a research community through a distributed network so that there was the ability for researchers to query patient-level data without violating the privacy of that data, because the data never traveled outside of Korea, and the researchers were submitting code and programs to be run against the data, but the researchers were not working hands-on with the microdata. And this is how these distributed and federated networks operate. And so this is a very exciting development, and how it really works, or the backbone of this method, is that the data are coded to a globally agreed common data model. So similar for the US FDA Sentinel surveillance initiative shown on the last slide, which also has a common data model that all of the participating organizations adhere to so that the data is coherent. The same thing is true for this OHDISI project and this common data model called OMOP. So this initiative in Korea that was really geared for COVID-19 research has great potential to provide a real-time or near real-time data surveillance tool like FDA Sentinel in the Korean context, but better than FDA Sentinel because this can cover the whole population. So there's a huge opportunity for meeting all those really interesting objectives for real-world evidence in Korea by leveraging on some of these new developments that were made during COVID-19. So let's just recap some of these expansion possibilities for Korea to consider. It starts with what's available for the DIR system and for pharmaceutical data at the national level in Korea. Can there be the extension to more clinical variables so that more is known about the dosage of prescription medicines and about diagnostic and test results for patients? And can there be more linkage to other data sets that will bring in population characteristics, environmental data, eventually even genomic data to really enhance the ability of that pharmaceutical data to really contribute to innovation, drug discovery, personalized medicine, evaluation of medicines? And how much more could the data within such a system be available in real time or near real time? There's a lot already developed in that direction in Korea, and there's just a few more aspects of the data that could be enhanced to be more timely. And then, if the investment that Korea has already been making in coding data to the OMOP common data model and in developing the DIR system itself, then could this Sentinel surveillance type system for Korea really be a possibility? So just to conclude this presentation by saying that Korea is already doing really well compared to other OECD countries in terms of health data availability, maturity, and use, and also health data set governance. This slide just summarizes what countries who have had the most success in developing a strong health information system have done to get there. And many of these elements are in place in Korea, and there are others that could be strengthened further. And we look forward to continued discussions with Korea as we develop the recommendations from our review of the health information system. And just to conclude again with congratulations on the development of the real-time data and the decision support tool that the DUR system has brought to improving drug safety. in Korea. Thank you very much.